Introduction to Nursing Concepts. This is the Hygiene Unit, Martha Olson. Hygiene is going to be something that we talk about with every patient because it's in home care, it's in long-term care, it's in your hospital patient as well. Social practices go down to things like what are they used to? What are their norms within that social practice? For my family, we had a boy from Greece that lived with us for a year, and when he came, it was something that he preferred to smell manly and have body odor because that's what he grew up with, but he soon realized that within our society, it was more acceptable to shower every day. Personal preferences: do they prefer a bath over a shower? Do they prefer to bathe at night or in the morning? When we think of body image, that becomes the teenager that showers twice a day because they have acne, they have maybe oily hair and skin. Socioeconomic is the patient that can't afford to shower, they don't have running water, they can't afford shampoo, and so oftentimes your public health nurse will have to kind of evaluate that situation. Their motivation might stem from not feeling good, not having the energy level. Many of your patients with chronic conditions simply tire too easily to be able to do their own bath. And then again, like I said, your cultures are going to vary. If the culture says that a man would not ever bathe a woman, a male nurse might then have to ask a female nurse to come in and help do the bath for that patient, so we can be culturally sensitive for them. Their physical condition, again, like I said, we need to see how tired they are, what they're going to be able to tolerate. Sometimes just a bed bath is all they can tolerate and they get very short of breath. Other times they're more able to wheel down and be able to pivot into the whirlpool tub, whereas they couldn't maybe tolerate a shower to stand that long for us. Assessment: a good time to assess the patient's skin is during that bath. I like to look then under the breasts and in the groin area and the coccyx area for any areas of skin breakdown, and so I as a nurse prefer to do as many of the baths as I can because you're kind of doing your assessment and the hygiene at the same time. The skin often reflects changes in that physical condition. When you look at the color of the skin and the health of the skin, it can often tell you what is going on inside of a person, as well as the thickness, the texture, the dryness, the temperature, and hydration of that patient. The skin is always changing, and so we have to continually assess that and meet the needs of the hygiene that's appropriate for the skin at that time. Encourage bathing. It does make a patient feel refreshed and renewed, and so oftentimes they'll rest better after we get them washed up and feeling a little better. Routinely assess that condition when giving care. Do they tolerate it, or do they become very short of breath? Oftentimes with your respiratory patients, we will check the O2 sat during the bath just to see how far that oxygen saturation goes down during the bath and how well they tolerate it. Again, we're looking for that dryness to the skin. I prefer to use Keri lotion, K-E-R-I. It's kind of an oily substance, but we put it in the bath water and it refreshes the skin without drying it out. Many of the hospitals are using the bath packs where you have the 7 towels in that blue pack that are throwaways. Those are very nice because they don't have to be rinsed off and they have the lotion in them that again moisturizes the skin. Your patient on a diuretic such as a Lasix is going to have very dry skin, and many times lotion and all of the things we can do to keep that skin from getting any drier is very important because we can't push a lot of fluids for them, and so we have to try to lower the temperature of the whirlpool bath for them because hot water dries skin even more, as does things like hot tubs and saunas. Look for any rashes or abrasions, especially if they have any braces or other appliances that they have to wear. And then for the skin, again, look in all those areas that tend to be a little more hidden because many times they will have maybe a yeast growing, or that skin is on skin and it gets moist and it rubs and causes skin breakdown to those areas. Developmental considerations: again, do they prefer a shower or a tub bath? At what age is a child able to take a bath alone is going to really depend on the child. It's better to be on the cautious side for them. And that's something that new parents need to be made aware of. They can never leave a child in the bathtub alone because they will drown very easily. That first bath for the newborn, remember we have to keep the umbilical stump dry, so we don't want to submerge that baby in water until that umbilical area is well healed. Provide modesty, especially for many of the cultures. They have a great deal of modesty, and we need to respect that for them. And then the congruent caregiver. In many cultures, it's very uncomfortable for a female to have a male caregiver, and so we would need to assess for that. And then if it was a male nurse, possibly ask a female to do the bath for him. The right hand is usually considered clean, and they eat with that hand, and the left hand is considered dirty, and they will do the wiping after the bowel movement with the left hand for some of the cultures that we have. When we look at self-care abilities, we need to document and assess that carefully, because that helps our social workers and doctors know if that patient is able to go home, or if they need to go maybe to an assisted living or long-term care facility for some rehab and strengthening, or if we can get home health to come in and do a bath 3 times a week for that person that is unable because of any physical limitations. Again, as I talked about, your energy level is going to determine a lot of what the patient is able to tolerate, because they just tire out too easily. If they're having pain, make sure you medicate well for the pain before we attempt to do the bath in the morning. And then look at those chronic illnesses. Do the hygiene activities cause shortness of breath? Do we need to be assessing for pain when we're doing range of motion and performing the bath for them? Some of the nursing diagnoses that go with this are listed here. Impaired physical mobility, again, are they able to get into a shower? Do they have a dressing or a wound that we would not want? So we need to do all of that. Many of your surgical patients that have wounds, the surgeons will tell them that they can go home and shower, take the dressing off, leave the dressing open to shower, and a shower is much cleaner than a bath, because during a shower the water runs right off, whereas in a bath all the dirty water from the peri area could potentially contaminate a wound. And so have very clear directions from a surgeon as to what the person can do when they are discharged home. Which nursing diagnosis would we select? As we read this scenario, we can see several things in here that tell us a good nursing diagnosis might be self-care deficit related to bathing, hygiene, as evidenced by body odor, dirt under the nails, and an unkempt appearance. Other nursing diagnosis that might fit with this lady with arthritis that has a lot of pain to her joints is ineffective health maintenance or impaired physical mobility. As we are planning care, we don't have to do every bath in the morning. Sometimes they prefer to have their bath at night, and it helps them sleep better. I also know that the day shift gets hit with a lot of rounds for doctors, new orders, walking, meals, and so sometimes it's better to do a bath at 5 in the morning when the patient wakes up and have that done for the day for them. Do they need a full bath? Do they have dry skin? Are they diaphoretic? Many of these things that we have to consider before we decide what type of bath. And as nurses' aides, oftentimes they will ask the nurse, what kind of bath do you want Mr. Jones in room 220 to have today? If they're real sweaty, I encourage a lot of bathing to keep that skin clean and dry. And some families will want to assist with that, or they're used to doing the cares at home and they will continue to do them when they are in the hospital. Otherwise, ask the patient's family to step out of the room when the bath is being completed. As far as implementation, things we need to teach for health promotion are bathing for a new mother. We often do a bath demo for the mother in the newborn nursery because they don't know how to do the bath, and that's something you'll talk more about when you get into your OB rotation for women's health. Do they have the motivation to perform hygiene? I remember one time I was working at the hospital, and the very first admission order for a new admit was to bathe the patient. They came from a home where they had animals. This woman had some skin breakdown issues, and she had a lot of fecal matter from the cats and dogs that was in her skin and wounds. And so that, for the doctor, was the number one thing that he wanted done on admission for that patient. With patients with dementia, sometimes you have to be very patient in bathing them because they don't tolerate that bath. Sometimes it's a matter of just doing part of that and then getting them dressed because they don't like that feeling of being naked. And so you might have to do, one leg and then put the pants back on and then do, maybe the upper part of the body later on when they're able to tolerate it. Favorite remembrance of a couple that he had Alzheimer's. She was trying to help us bathe him, and she said to him, "Honey, we might be old, but we do not have to smell old." And so that was her way of trying to get him to help us with the bath. When we look at oral cares, remember back to the oxygenation unit where we talked about the importance of doing oral cares after your breathing treatments, your albuterol nebulizers, or any of your inhalers. That's so they don't grow thrush, because remember that oral cavity is warm, it's moist, and bacteria and things like to grow in there. When we look at some of these terms, your stomatitis, remember, is inflammation to the mouth, where the glossitis is the tongue. We're seeing more of that with some of the tongue piercings that people are doing. Inflammation of the gums is your gingivitis. Halitosis is a nice way of saying they have bad breath. And then chelosis is cracking of the lips, but it can also be a B vitamin deficiency that we can see. It's important to examine the mouth, see if the dentures fit correctly, what the condition of the teeth is like, and then we know from research that oral cares done frequently are going to help our patients to have less pneumonia and other nosocomial infections. To implement oral cares on somebody that's unconscious, remember they could aspirate. So the book in Potter and Perry shows you how to turn the patient to the side to make sure you have suction, and to do oral cares frequently, but be very careful they aren't aspirating any of that fluid down. Make sure oral cares are done at least every 2 hours on many of our patients. And then it talks about diluting some hydrogen peroxide with half water to loosen any crusty things in the mouth or on the lips. And then keep the lips as moist as we can with some kind of lip balm. With dentures, read the Potter and Perry as to how to care for dentures. You had that content in the nurse aid class that you were required to take. But remember, we need to keep them moist, so when they take them out for the night, make sure they're put in some tepid water. Don't ever wrap them in napkins or things at the bedside, because they can easily get thrown away. And dentures, besides being very costly, usually fit a patient, and to get new dentures can be a very problematic situation for them because they may not fit exactly like they need. With stomatitis, in the book it talks about who would be very high risk for stomatitis. Anybody with a tongue piercing, poor oral care, your patients with chemo, radiation, anybody with an immune system that's not strong like HIV, or your patients with lupus, very high risk for getting stomatitis. Anybody with an NG tube that's been inserted, or your smokers or patients that chew tobacco have very high risk for stomatitis. Our treatment for stomatitis then is a soft toothbrush. A normal saline rinse is talked about in Potter and Perry 4 times a day. Gentle flossing. Avoid any alcohol or smoking for the patient. And also for stomatitis, avoid using any mouthwash that they may have. Our last slide for today in this segment of hygiene then is going to be hair and scalp. Dandruff, there are shampoos for that. Otherwise, we would want to make sure that it is not pediculosis or a problem with ticks. Make sure then that with ticks, we do not pull them from the skin because they can become infected, but the book talks about putting a drop of oil on the tick to cover it. For your head lice or pediculosis, it would be called capitis pediculosis if it's in the head. Corpus is body, and pubis is to the pubic area. And working in drug and alcohol rehab, that was unfortunately something we had to deal with quite a bit. The toxic effects of the Quell shampoo need to be highlighted and thought about because they can cause neurological changes for the patient. That ends this first portion of the hygiene unit. Thank you.